Bismillahirrahmanirrahim. This video will describe some of the examples along with case scenario that are related to the inflammation. A 45 years old male presents with red, swollen and warm left lower leg following a laceration injury 24 hours ago. The microscopic examination shows neutrophilic infiltration in the tissue. The explanation, pathologic explanation for this scenario is the sequential cellular response to injury. Here, there is margination, rolling, adhesion, diabetes, and then finally chemotaxis occur. And the key adhesion molecules for this process, inflammatory process, are selectins, integrins, and the neutrophil migrate to site of infection via chemokines. Then the clinical relevance of this condition is that the patient is having acute inflammation, and if the leukocyte they do not adhere properly or fail, there can be recurrent bacterial infections, or if the process is prolonged, there can be potential abscess formation. A 60-year-old diabetic patient presents with non-healing foot ulcer that has foul-smelling discharge. The gram stain revealed Pseudomonas aeruginosa. So the pathologic basis is that the diabetes impair leukocyte extravasation and chemotaxis due to metabolic dysfunction, and the neutrophil dysfunction lead to poor bacterial clearance, and this allows biofilm formation by the Pseudomonas. The diabetic patient in this scenario is having impaired neutrophilic function and delayed wound healing. That is leading to chronic infection. The chronic wounds in diabetes have got an increased risk of amputation if left untreated. So management of these conditions requires improved glycemic control with prolonged broad spectrum antibiotics. This is another scenario in that the 5-year-old child presents with a recurrent Staphylococcus aureus and Aspergillus infection. Nitroblue tetrazolium test is negative. The pathologic basis for this scenario is that there is NADPH oxidase deficiency that impairs the respiratory burst, and the reactive oxygen species are not formed. So there is defective intracellular killing, and granuloma is formed because the immune system will attempt to wall off the persistent infection. This patient is having chronic granulomatous disease due to NADPH oxidase deficiency. Frequent infection with catabolase positive organisms such as Staph aureus and Aspergillus are seen. Prophylactic antibiotics and interferon therapy improves the outcome. This is a case of 28-year-old woman who developed painful oral ulcers and erythematous skin lesions. Lab results show high ANA titers, and a biopsy revealed immune complex deposition. The pathologic basis of this scenario is that there is defective clearance of apoptotic cell and persistence of inflammation, and there is failure of secretion of interleukin 10 and transforming growth factor beta. So there will be chronic inflammation. This patient is having systemic lupus erythematosus, where failure to resolve inflammation leads to autoimmunity. So these autoimmune diseases result from failure of inflammatory resolution mechanism. Management of this condition is by corticosteroid immunosuppressant. In this scenario, a 40-year-old patient with septic shock presents with hypotension, fever and tachycardia. Blood culture shows gram-negative rods. So the pathological basis of this scenario, the lipopolysaccharides from gram-negative bacteria, they trigger toll-like receptor 4 that are present on macrophages, and they initiate cytokine storm, that is the overwhelming concentration, very much increased concentration of tumor necrotic factor alpha, interleukin 1 and interleukin 6. There is massive dilation of the vessel along with endothelial damage that will lead to hypertension and organ failure. This patient is having endotoxin mediated systemic inflammation leading to sepsis. This is a life-threatening condition. Early fluid resuscitation and broad spectrum antibiotic use is critical in this condition. Anti-TNF therapies are also being implicated in this sepsis. In this scenario, a newborn presents with delayed umbilical cord separation, recurrent skin infection, and no pus formation. The pathologic basis is that there is impaired leukocyte adhesion and migration that result in defective wound healing. No pus is formed due to defective neutrophils. So this patient is having leukocyte adhesion deficiency due to CD18 integrin deficiency. It has got high mortality if untreated and requires bone marrow transplant. In this scenario, a 32-year-old woman with systemic lupus erythematosus develop glomerulonephritis. So the pathologic basis is that neutrophilic extracellular trap, they release nuclear chromatin that are DNA and histones, and these then form autoantibody against these structures. So there is impaired clearance of net, and then lupus nephritis develops. This patient is having SLE, and this SLE autoantigen production is caused by this neutrophilic extracellular trap, and hydroxychloroquine is helpful to reduce immune activity. A 55-year-old man present with chronic cough, night sweats, and weight loss. Chest X-ray showed upper lobe cavitation. So there is macrophage activation via interferon gamma, and granuloma is formed, and it contains Mycobacterium tuberculosis. Failure to contain infection will lead to caseous necrosis and lung cavitation. This necrosis and types of necrosis we will study in the necrosis lecture. So this patient likely having tuberculosis that causes granulomatous inflammation, and TB treatment is a prolonged treatment. It is a multi-drug treatment, containing isoniazid, rifampicin, pyrazinamide, and ethambutol. Here, a 68-year-old man with history of gastroesophageal reflux disease presents with progressive dysphagia. Endoscopy revealed esophageal strictures. So, pathologic basis of this scenario is that there is repeated injury and the fibroblast activated due to this repeated injury and excessive collagen is deposited. Transforming growth factor beta promotes fibrosis and esophageal strictures are formed. So chronic exposure leads to fibrosis and stricture formation in gastroesophageal reflux disease, and this structure treatment is by dilatation of the structure and proton pump inhibitors. A 50 years old woman with rheumatoid arthritis experiences morning stiffness and joint pain. The basis for this condition is that there is persistent synovial inflammation that lead to joint destruction. Tumor necrotic factor alpha drives inflammation, so anti-TNF drugs are implicated in this disease to reduce the disease activity. This patient has got autoimmune inflammatory disease, rheumatoid arthritis that can manage with this therapy. Thank you for watching this video. If you have any question, please write in the comment box.